Today we're discussing pain control with local anesthetic. Today we're going to break it up into several chapters. Basic pharmacology, the classification of local anesthetics, the mode of applications in clinical use, with a special focus on tumescent. Obviously we're going to focus also on safety and efficacy, recognizing possible complications, treatment of those possible complications. We'll present clinical scenarios demonstrating techniques in local anesthetics. We need to go back to our basic pharmacology. It's been a long time, but we need to review how does local anesthesia work. The delivery of a message down the nerve action potential depends on the interplay of ion channels opening and closing along its membrane. Particularly, sodium ion channels are in focus. Local anesthetics work in a clinical application by reversibly blocking these sodium channels to present the effective clinical desired result. Which nerves are affected? Different nerves have different roles, of course: pain, temperature, proprioception, motor control. But we're going to focus on the C and A delta nerve fibers, which are susceptible to the reversible action of the lidocaine and other topical anesthetics that we're going to discuss today. How do we classify these? The broad classifications are between the esters and the amides. We're going to focus on the amides, which include lidocaine, bupivacaine, prolicaine, bupivacaine, of which the first two are the focus of our talk today. During the history and physical and other preoperative workup, the practitioner must be acutely aware of anything that affects the clinical metabolism of these local anesthetics in the liver. Further, we can classify these local anesthetics in their duration. How long does it take for the clinical effect to be metabolized? These are between the ultra short, 30 to 45 minutes, short, 60 to 120 minutes, medium, 2 to 4 hours, and the long-acting and ultra-long-acting, which may be in different preparations such as liposomal bupivacaine. Today's focus will be on lidocaine, which is in the short classification in the 1 to 2 hour range. Further, we may classify them through mode of application. Today we're going to focus on the topical and the tumescent techniques. However, be aware that the local field blocks, such as nerve blocks, as in peripheral nerve blocks by anesthesiologists, are also available, but in a typical cosmetic practitioner's office, the topical and tumescent techniques are predominant. Pharmacokinetically, the successful action of the local anesthesia on the nerve potential depends on the dissociated base form. We've got to go back to our chemistry and to say, basically, in an acidic milieu or environment, the local anesthetic tends to be less effective because the local pH and the pKa of the particular agent may be hampering the dissociation of the ionic channels. Simply put, the closer you make the environment to the pK of the body, the faster the local will affect. Clinically, we use sodium bicarbonate to buffer the natural acidity or pKa of the local anesthetic for the following indications. It actually makes the injection in the awake patient more tolerable, as well as making the efficacy of the local anesthetic greater with faster onset. Further, what effects do these local have on the body besides analgesia? We must be aware that vasodilatation, or clearing the local faster, the shorter, may actually hamper the duration of the effect of the agent. So we often incorporate a vasoconstricting agent, typically epinephrine, in our combination treatments. As mentioned, the acidic environment, due to either the pK or local pH, or for other clinical scenarios such as infection or inflammation, may also lower the pH or pKa, so that the efficacy may also be further lessened. That must be taken into consideration. There's also increased lipid solubility of the local anesthetic, so depending on the amount of adipose tissue, that also may affect the clinical effect. Adding sodium bicarbonate also can further make the environment, the pKa and pH, more in line, making the effect quicker and more effective as well. We'll also touch upon topical local anesthesia, but the focus of today's topic is more on the advanced techniques of tumescent and other injections. We are all aware of the efficacy of these agents, but we also have to be aware that the patient compliance and information that is given to them is accurate. Seemingly innocuous topical applications of these agents can be actually dangerous in certain scenarios that are not clinically warranted. Patients may actually find on the internet and other sources of misinformation that using occlusive dressings with topical anesthetics on the skin will aid and make the effect quicker and faster. While this may be true, it also may have an unintended effect of having a local anesthetic toxic event, and patients must be warned accordingly. Next. Injectable local anesthesia is the most common form of local anesthesia, and this is done usually in the surgical or procedure suite for very specific indications. While we're going to focus on the tumescent technique for what we're going to do today, but this is something that is also available. Regarding lidocaine in particular, we also want to be aware and cognizant of the maximum dose. This varies from the mode of injection as well as the local anesthetic itself. Lidocaine, for example, injected has a 5 to 7 milligram per body weight kilogram maximum dose recommendation on the product insert. This varies whether a vasoconstrictive agent is used or not. This is also different in the tumescent arena, which we'll get to in further detail in the following slides, but please be aware of the respective maximum doses of each agent. Injecting large volumes of dilute local anesthetic into the subcutaneous tissues to improve pain and hemostasis following liposuction is a must. Regarding tumescent anesthesia formulations, there are variable forms, but suffice it to say, in the awake patient in particular, the potency and overall dosage of the local anesthetic given to the patient tends to be higher than when a patient is under sedation or general anesthesia. For example, the Hunstad formulation, as you see on the slide, is a 0.05% concentration lidocaine. What that means is there's a variable between that and what is commonly known as a Jeff Klein formulation or derivation of up to 1 milligram or 0.1% concentration. We will provide some examples of these formulations, but we will leave it up to individual practitioner to figure out what is the best mode of formulation for him or her. Regarding the volume of tumescent anesthesia, some practitioners describe differing volumes: dry, wet, super wet, and tumescent techniques. For today's clinical scenario, Dr. Katz will demonstrate the tumescent technique, which is on the larger volume side of the spectrum. Advantages of tumescent technique include decreased blood loss, decreased bruising and swelling, improved analgesia. In fact, most of these patients have complete analgesia and just feel the proprioception or vibration of the devices. Otherwise, they're very, very comfortable. Also, there's more rapid discharge from the surgical facility and decreased IV fluid requirements, especially with the larger volumes of isotonic saline that we use. Some disadvantages we will also focus on later on is lidocaine toxicity, epinephrine toxicity to a much lesser degree, fluid overload, and pulmonary edema, which is not really an indication for a cosmetic procedure, which would be sussed out preoperatively, but something to keep in mind during the clinical application of the tumescent technique. Regarding safety, there are different maximum loads of lidocaine that have been provided in the literature. Commonly, 35 milligrams per kilogram body weight has been used, but there are other literature that has demonstrated up to 50 milligrams per kilogram safety. For the purposes of this talk, we will be restricted to the 35 mg per key protocol. It is also known that the peak levels of plasma concentration using the tumescent technique is 6 to 12 hours post-injection. And the analgesia may also be quite drawn out, which is to the clinical advantage of the patient and practitioner. Local anesthesia complications with misinjection may occur with skin necrosis, muscle necrosis, intraneural injection, prolonged motor and sensory deficits, as well as unintended vasodilatation. These are very rare complications, but may occur when the practitioner is not experienced or aware of the anatomical implications. More importantly, systemic anesthesia complications may occur when improperly dosing the patient with the local anesthetic agent. This usually occurs in a temporal or chronological event where a patient may elicit symptoms and signs in various orders. First, central nervous system symptoms such as a dizziness, perioral tingling, as well as a higher level anxiety may occur. In higher toxic levels, cardiovascular symptoms and signs may occur, which include hypotension, bradycardia, decreased stroke volume, and peripheral vasodilatation may all contribute to cardiovascular collapse. Of course, the most important thing to avoid this complication is proper preparation and preoperative evaluation. However, if these do occur, the practitioner must be acutely aware what to suspect. If you suspect a systemic toxicity of a local anesthetic agent, you need to act quickly and definitively. Maintain the airway. Introduce supplemental oxygen, preferably 100% via face mask or ventilator. Support the blood pressure drop with IV fluids as well as pressors as indicated. And benzodiazepines may be helpful for the CNS effects, particularly seizures. As a highly lipophilic agent, most of these local anesthetics are responsive to scavenging with intravascular lipid emulsions. At any rate, EMS should be contacted immediately while administering these interventions. Now we're going to be in a procedure room to demonstrate the clinical applications of the various local anesthesia techniques for the office. Today we have Milena Justo, who's my registered nurse for the state of New York. Please refer to your individual state Department of Health guidelines regarding the various responsibilities that the clinical assistants may and may not do. Once again, there's a disclaimer, this is for informational purposes only, and please refer to your own professional background or professional for application of these techniques. Well, today we're going to go over the tumescent technique, and a modified Klein solution is what we use as a bulk of our procedures, both in body contouring as well as for the less invasive procedures such as microneedling, resurfacing, and the like. This 500 cc bag that Milena is holding up is a workhorse volume. Of course, you adjust the concentrations accordingly. For this volume of saline, we'll put in a like-minded amount of lidocaine, epinephrine, buffering solutions such as sodium bicarbonate, and then a delivery system. We'd like to draw the viewer's attention to the fact that the tumescent formulations are individual and up to the individual practitioner's expertise, and there's not one cookie cutter that fits all recipe. For example, we want to strongly emphasize that commercially available products such as these should never be directly injected into the patient without the proper diluent. We will refer back to the didactic portion for the reasons of lidocaine toxicity and its attendant complications that may ensue. So we want to emphasize that once again. We have Wanda Cummings, RN, who is our VP of Clinical Training, as well as Lisa Metler, Physician Assistant, one of our senior clinical instructors. We'll start with a topical option, move on towards various injection techniques, adjunctive therapies such as nitrous oxide and other things that enable the local anesthetic to work even better, as well as other techniques. These will be time-stamped and chapter referenced for the viewer's ease of referencing, and these will include topics such as topical, various injective techniques, adjunctive therapies, PO meds, and the like. I'd like to introduce Wanda Cummings as, again, the VP of Clinical Operations, and she's going to talk about topical anesthetics in the clinical applications in the office space.
We commonly recommend a topical agent such as 23% lidocaine with 7% tetracaine compounded either in a lipo 110 base or a plasticized gel. Now, when we use these topicals, we have to be very conscious about our lidocaine toxicity dosage. You can easily get this, how many grams per kilogram that you can use, from your compounding pharmacist. So it will, at times, could limit you to the amount or the areas that you can cover in one treatment. In combination with the topicals, many times our providers will add Pronox, which is a 50% nitrous oxide and a 50% oxygen. It gives them very good anesthesia. They might feel the procedure, but they're comfortable with it and they really do not care. Another thing commonly used when we do topical, it can be either oral medications that your medical director recommends and a Zimmer chiller. If you have a Zimmer chiller somewhere around in your site, which many do, they work great for anesthesia in combination with the lidocaine or the topical.
Okay, now I'd like to go through direct injection techniques with a variety of modalities. So you can start from the minimally invasive to a little more moderately invasive. And one option you can do is use a spinal needle, and I will typically use a 20 or a 22 gauge spinal needle, and you basically take out the inside and you can just attach it to a needle itself. Okay, that's one way to inject if you're doing a small area. Other options we have are something called mesoram needles. These we find on mesoram.com. You can attach a syringe to it with your local anesthetic, and this specifically is 30 gauge needles, 4 millimeters in depth. They do come in all different sizes, in different varieties. We also have a 3-point needle and then a 5-point needle. So these can attach to either a syringe or what I'll demonstrate in a moment in this technique, which is a closed loop system, which I'll demonstrate. Okay, so let's do that first. So the first thing you do, take off the protective sleeve here, and as Wanda's demonstrating here, you'll pull the tab, and then we'll spike the bag. Okay, I always like to have this closed until I'm actually ready. Okay, and then we'll open it, and basically you're self-infiltrating. This is going to make a noise. Okay, and the fluid will then come into the syringe. Once it's in the syringe, we're ready to go. And then you can attach whatever modality you'd like to use to start injecting. So whether it's the mesoram needle, you can inject. You can attach the spinal needle and inject. And the advantage of this device is that it self-fills. So instead of using a large syringe, such as a 60 ml syringe or a 20 ml syringe, where it takes a lot of hand strength, this is a great way to make it easier on the provider. The other option you have with this is you can actually attach your infiltration cannula, because it is a Luer lock. And again, if you don't have a peristaltic pump, you can use this as a way to infuse your tumescent. And at the end of this production, we'll put a resource slide that will give you the companies that you may purchase these from. Mesoram.com is one of them, and Custom Medical Supplies is the other. And of note, we do not have any commercial interest in any of these companies that we are demonstrating their products. Now we mark the patient prior to coming into the room in a standing position. Now Dr. Chia is going to demonstrate how to infiltrate the tumescent. We've cleansed the patient with chlorhexidine. However, you can use a variety from chlorhexidine to betadine to alcohol. You just want to make sure that any residue from a topical anesthetic is completely removed and the area is clean and dry.
We have a lovely 41-year-old patient, and she has in very good shape athletic-wise. She has a little bit of a complaint of a supraumbilical and infraumbilical laxity that we're going to really address with the radiofrequency microneedling technique. Because it's such an effective technique, it does elicit some stimuli from the patient that may be uncomfortable, so we want to make her as comfortable as possible so we can focus on the efficacy and safety of the treatment. In this regard, we're going to choose the local tumescent technique. When we're not going to undergo liposuction, we do not need to do an access incision. We can merely use a 30 gauge with 1% for access and a 20 gauge spinal needle for delivery of the tumescent solution. That way there are no permanent scars at all, because it's actually smaller than a vacutainer that's used for phlebotomy. In that regard, we're going to go ahead and get access here, pinching to distract, coming at a steep angle, going in before injecting. Once then we pulse deep in the subcutaneous tissue, which is less richly innervated, pulsing in order to let the quick-acting lidocaine do its thing, and then retracting towards the dermis. By then, we get to the superficial portion. She has a very good area of numbness, thank you, as well as a visible wheal. How are you doing, okay? And she's nodding her head. I'm going to use that as an axis. Once again, to the 20. Pop through, and she's good. We want to go low and slow like barbecuing. And so our rate of infusion in this particular pump, which is a peristaltic pump, will be about 100 mLs per minute, very slow, and once again in a deeper subcutaneous plane. You okay? Great. She's nodding her head in the affirmative. And just letting the hydrostatic force of the fluid do its thing, because once again, lidocaine acts very quickly, and so the front of the hydrostatic force, if you will, actually will be the leading edge, and by the time you advance the needle, the analgesic effect has already been begun. And Ryan has a beautiful shot of the close-up here. You can see the infiltration going there. How about volumes? When we talk about volumes, it's not quite tumescent, super wet, or even that regard. As a rule of thumb, if I'm going to do contouring with liposuction, if that's 1 or 100, I would use about 30% of the volume here for that. Once again, we refer to your medical director's preferred formulation for the tumescent. I'm going to go ahead and do half of this area in a fan-like pattern so that the other half may be demonstrated by Lisa in the mesoram technique.
What kind of infiltration pump are you using?
It's just a standard Wells-Johnson peristaltic pump with standard tubing, but you can use anything that is readily available. We do a lot of contouring, so that's readily available in our office, but if you're just in the procedure room, you can use the 3-way stopcock continuous infusion technique, which is great, or even handheld syringes, which is a preference if you're doing small volumes. Okay. For offices that are not equipped with peristaltic pumps, you're certainly not obligated to get one. There are many other low-cost, efficient options to deliver effective analgesia. Lisa will demonstrate the continuous flow 3-way stopcock, where you don't have to take the needle off of the syringe, and that just increases time, increases risk for error, and also may compromise your overall effectiveness of the analgesia because you're not paying attention as much. This is a good way to really deliver it continuously. We've already anesthetized with 1% with lidocaine at the periumbilical region, and she's doing the same fanning technique. Any other comments, Lisa, on this technique?
As you can see, I'm going to the extent of my markings here. So I'm injecting to the extent of my markings here to make sure we have good anesthesia all the way to the end. And as you see, this will just fill up for me, and I'll just keep infiltrating slowly.
I noticed that with the spring action, it automatically reloads as you release the plunger.
Yeah, which makes it very easy on the hands. It's a very smooth way to infiltrate this in a fairly quick matter.
And also, there's no toggle or any type of 3-way stopcock to actually manually change. It automatically fills and then closes off with positive pressure, correct?
Correct. The other advantage of using a spinal needle is that, you really can go anywhere. Once you have anesthesia in, she should be totally comfortable for me to inject. So instead of going around a corner, you really want to stay in a nice, smooth, straight plane. You know exactly where the tip of your needle is at all times.
Of course, the practitioners can always use individual syringes if you wish, if that's what you have. Utilize whatever resource you have in the office already.
Okay, now we can switch over to the mesoram. You okay? So we have two options here. One is a 5-point, so these are 30 gauge, 4 millimeter, And these are 30 gauge 4 millimeter as well, just a different configuration. I would say if you're going to be using the Morpheus body, that you could order the 6 millimeter so that you'll have the greater depth of penetration. And basically you just want to make sure that you're going in, depositing anesthesia, coming out, and staggering. You're about 1 centimeter apart with each injection.
How much volume are you doing per injection site?
Doing about 1 cc per injection site.
Do you sometimes add topical if the patient's waiting for the procedure room?
Yep, or Pronox is this is
Pronox.
where Pronox would be a great option, right? Because they could be using the Pronox while we're doing this. And
Actually, we'll have Milena will go ahead and sub the Pronox as an option for our patient. Would you like some?
Sure. Why not?
Sure. I think it would be helpful. Once again, the Pronox, we have no affiliation with Carestream USA. It is a 50% nitrous oxide, 50% oxygen delivery system. There's a flutter valve in a one-way direction. It's not continuous. The only way you can instill the nitrous oxygen mixture is to have negative pressure upon inspiration. And the patient holds the device in his or her own hand. There's going to be a little alarm system that indicates that it's engaged. That's the oxygen tank as well as the nitrous, which is not as loud. But those are normal sounds. Lisa will keep engaging the mesoram technique. As Lisa continuously uses the peristaltic pump with the spinal needle, we just want to make a note that while many practitioners are comfortable using a sharp instrument with a relatively long draft, we want to maintain that the practitioner maintain within his or her own comfort zone. And we wanted to apply as many different options for this technique, which are, and at the end, equally safe and effective in one's respective comfort zones, as mentioned. That being said, she has received about 10 milligrams of diazepam, 5 milligrams of hydrocodone with acetaminophen, 325, and is utilizing on her own volition the 50% nitrous oxide, and she's good with that. Thumbs up, okay, that's helpful. Other things to do is prep the area with topical analgesia, as Wanda had gone in another segment. And all these things all together can be wonderful adjuncts to fit any practice in all scope of practices, whether it be surgical, medical, dermatologic, or other. And you can make sure that you have a safe, effective delivery of excellent analgesia so that you can concentrate on maintaining a good service for your patients.
So now that she's anesthetized, we're going to use the Morpheus body handpiece. We have these settings at an energy of 10, on burst mode at 7 millimeters, which will deliver energy at 7 millimeters, 5 millimeters, and 3 millimeters. So the correct technique is to first stretch the skin so you have a good area of tissue to treat. So you're going to place the tip at 90 degrees, depress the foot pedal in a firm position, and move on to the next side. You're not overlapping. Each one press of the foot pedal delivers 3 pulses of energy. See how I'm continuously stretching the skin to maintain a smooth surface? I'm keeping the area dry. And she's completely comfortable. Firm pressure. You don't want to place it like this and have the handpiece lift up. You continuously stretch and apply firm pressure. You can do a second pass in the opposite direction. That way you will not miss any spots that you did in the first direction. How's that?
Colleen, can you give us a thumbs up with your right hand?